Hello and welcome. On behalf of CME Outfitters, I'd like to thank you for joining us for episode 3 in this 4-part CME Outfitters snack series titled ADHD Can Be a Moving Target. Equip yourself with the tools to detect and manage ADHD and reduce its burden. Today's episode is titled Moving Beyond Limitations in ADHD Management, Best Practices for Personalized Therapy for Children and Adults. And this CMEO snack series is supported by an educational grant from Takeda Pharmaceuticals, USA. I'm Dr. Ann Childress, president of the Center for Psychiatry and Behavioral Medicine, and also on faculty at Touro University, Nevada College of Osteopathic Medicine, and the University of Nevada, Las Vegas School of Medicine in Las Vegas, Nevada. And I'm joined today by my colleague, Dr. Tim Willens, Chief of the Division of Child and Adolescent Psychiatry and co-director of the Center for Addiction Medicine at Massachusetts General Hospital. He's also a professor of psychiatry at Harvard Medical School in Boston, Massachusetts. Tim, welcome.
Hi, thanks, Ann.
To frame our discussion today, let me review our learning objectives. Our goal is that after this CME snack, you'll be able to develop a personalized treatment strategy for children and adults with ADHD and consider individual preferences and goals with your treatment strategies, in addition to thinking about medication safety, efficacy, and formulation. Tim, ADHD impairments change as an individual ages, so likewise, the goals of therapy need to change. Would you discuss changing needs and treatment goals as children transition to adults?
Absolutely, Ann. And in fact, it's very interesting because when you think about it, in preschoolers, really, when you've got young kids, they're presenting because of a lot of the behavioral issues. They're hyperactive, they're overactive, et cetera. But the biggest reasons for referrals into child psychiatry, pediatrics, family medicine for ADHD is really school underperformance and academic issues. And that's really in school kids. So you're really going to have to start now thinking about that through the day, after school, but you're also keeping an eye on things such as their behavior itself, disruptiveness, dysregulation, and their self-esteem issues. This continues through adolescence. And now you got to start worrying about smoking. They start driving. You start working now, there are legal issues for behavioral problems. That persists into college age kids, and we call them transitional age. Those are going to the trades, going into college. You're worried about continued academic underperformance, and those people going into the trades, their abilities to manage all of the things being thrown at them, and start adding now smoking, substance use issues, and again, really driving. And finally, in adults, all of this continues, and add to it interpersonal issues, problems with their occupation, relationship issues. And so your targets change based on how the person is growing and what age group they're at, and then what are the demands of whatever specifics that person is doing.
Got it. Well, we know education, support, and treatment selection are key components to developing an effective treatment plan. Can you discuss these components with the audience?
Absolutely. And in fact, some of the things we have to do that are really important is really start with education. What is ADHD? What are the things that we're working on, some of the problems, but also what are some of your strengths? I am a big advocate that you identify some local and some online resources because people are going to be looking on the internet. You don't want them going to sites that you don't think are good sites. So there's a number of sites. The American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, APSARD. There's CHAD, which is a support group, Add-In, which is a support group. These are legitimate, and these can be very helpful, and they can join the organizations, et cetera. You're going to want to help guide them in implementation of accommodations that they may require. It may be in school. It may be at work. It may be at home. And also some lifestyle issues. Some kids require extra time for tests, and some are going to require quiet workspace. I had a kid I saw recently in clinic, for example, and he's doing fine, but was getting overwhelmed during test taking. And it had to do with distraction in the noise. And the solution to this was not a major accommodation. It was moving the kid into a different part of the classroom where they could, when they took tests, it was quiet. The anxiety reduced and the attention got better without changing anything else. The other issue is you really want to think about, for some individuals, vocational assessment if they're struggling, and career counseling. Some of it is to ensure they get special accommodations or special, they go to the correct parts of the school that they're attending that may have accommodations for them, learning disability programs, et cetera. And some of it is for people who are just probably not doing the right thing. Their ADHD is interfering and they may want to think about a change. And finally, I think you really have to set expectations that are reasonable for both medications and for psychotherapies. In terms of treatment, if you're thinking about adult ADHD, let's start with adults. Really, pharmacotherapy is what you're going to start with and add on cognitive behavioral therapy. That's what international guidelines recommend, such as the Canadian guidelines. You're really going to have to think about, when you're thinking about treatment, what about other issues that the individual has? Are there other learning problems? Is there psychiatric co-occurring problems, anxiety, depression? Is there substance issues? Do they have medical comorbidities? Is there cardiac issues? Things like that. You also have to know the individual. Is this somebody you're worried about who's going to misuse stimulants? Is this a woman of childbearing age that's thinking of getting pregnant or is at high risk of getting pregnant? Or maybe carrying a child and they're discussing with you postpartum care. The other issue is you're thinking at an individual level about what kind of response are you looking for? What's the likelihood for good tolerability? And I think it's a big issue with adults that you think about the workday. How are they getting to work? How are they getting home? And what kind of struggles might they have at work? What's going to be that day of coverage for them? If you're talking about young adults, especially those who are transitioning, I have to tell you that transitioning period is a risky period. I always say you do everything right as kids are growing up and you get good diagnosis of ADHD, you get your treatments all solidified, parents have worked really hard, and then they launch and you don't have services for them, and that can be a real problem. So this is a time that you really need to ensure that they're being monitored carefully, that they've got some structure around them, et cetera. And again, the comorbidities are so common. It's the majority of cases. Only 20 to 25% of cases of ADHD don't have some kind of comorbidity. And you really are going to have to think about those when you're working with them.
And one of the problems with clinical trials is that those 20 to 25%, those are the ones we're trying to get in. So we're looking at medications and how they work with a minority of patients that have the disorder, right?
It's absolutely correct. And it's one of the reasons that sometimes dosing and how you titrate and the outcomes are a little bit different in clinical practice than you see listed in the pharmacologic trials.
That's for certain. You talked about medication options, and they do vary by dose and formulation and duration of effect. Can you briefly review some of the methylphenidate formulations?
Absolutely. And Ann, I always say, the good news is we have so many options now available to us with the stimulant medicines, in particular methylphenidate preparations. And the bad news is we have so many options available to us that it can get confusing. So I think it's helpful, for each individual to pick a few of the different methylphenidate preparations to start with, but then to have some kind of a resource there to help you if you have patients who may require something that isn't so cookie cutter. I find it really important to get it right when you're talking about titration and stuff. You're going to hear that recurring theme between Ann and I, and that is picking the right medicine, picking the right formulation, and getting the dose just right. Kind of like the old analog tuners that you used to have, the radios where you got the radio station close and you really want to narrow it down and get it perfect. So if you look at methylphenidate here, I think a few things that are helpful to know is that you've got standard methylphenidate, and then you've got isomeric methylphenidate. The formulations vary, and that we're going to talk a little bit more about that, but it's really important because some kids can't tolerate certain formulations, certain comorbidities like autism spectrum. Other people just simply can't take pills, or there's other requirements to consider. I think it's really helpful to know that dosing is important, and in general, we tend to underdose the stimulant medications, and that the the maximum dose, and there are guides to maximum dose in various texts that exceed FDA approved dose. We appreciate that, but there's safety data to show that you can go up on these doses and monitor them carefully if necessary, and often exceeding FDA dose. And the other probably most important component is the duration of effect of the medication. Do you want a short acting? Do you want an intermediate acting? Or do you want an extended release? And then within the extended releases, now it used to be just an extended release. It varies. You can go 8 hours, you can go 12 hours, you can go 13, you can go to 16 hours. And it becomes important in terms of being able to balance that with methylphenidate preparations. How much do you require to get you through the day versus how much is causing problems with appetite, with sleep, and other things that may occur.
That is a great summary. And I love the fact that you talk about become familiar with a few, get really good at dosing and titrating a few of the medications. And then if there's a problem, if you're looking at something and your go-to takes a little while longer to kick in the morning, if you have somebody that's having trouble in the morning, getting off the bus, getting to school, you might want to pick something else that starts a little quicker, right? A lot of methylphenidates available. There are some amphetamines too. And it's my understanding that amphetamines are really more often prescribed in the adolescents and adults.
You know, it's absolutely correct, Ann. And you know, I think that there have been meta-analysis on this that have actually, you know, commented on that effect, that you may actually get better effect with amphetamines in adults. And there have been some recent studies that show good outcomes with amphetamine in adults. I still think it's your individual choice. And I know that when we've audited our own practice, where we see a lot of ADHD, about half of our patients are on methylphenidate and about half are on amphetamines. And speaking of the amphetamines, again, you have multiple choices here of amphetamines. Now, just to remind you, amphetamines have longer half-lives. Both they last longer in the blood, and they have a longer behavioral half-life. So your short-acting ones are actually going to be longer than methylphenidate short-acting. The other considerations with amphetamine is there's more sort of, people forget this with the amphetamines, that you have various salts and various isomers of amphetamine. And the amphetamine that's going to give you the most efficacy with the least side effects are going to be the isomeric ones, like your dextroamphetamine or lisdextroamphetamine. In terms of the formulation, again, we're in very good shape because you have a number of different formulations, from tablet to capsules, disintegrating tablets. With amphetamines, in general, they're about twice as potent, which means that you're going to require about half as much as methylphenidate. For your dosing is going to be lower. And when you think about maximal dosing, in general, we usually don't go much higher than 1 milligram per kilogram in kids. And most people max out around 100 milligrams in adults. Again, that's going to exceed FDA approved dosing. You don't start it at that dose. You titrate up slowly. But in people who are tolerating medicine, who may require multiple doses, et cetera, that seems to be a reasonable cap. The duration, again, is anywhere from typically 5-6 hours up to now compounds that go to 16 hours a day with a single morning administration. So you have this wide variety of the types, the release mechanisms, and the formulations, as well as how long the amphetamines are going to actually last in terms of their efficacy against ADHD through the day.
What do you think about the advantages and disadvantages of using stimulants with ADHD? You talked about some of them with worrying about misusing them, but there are other issues too.
Yeah, so I'm going to start with the advantages to using stimulants in general, and that is that stimulants are the most effective agents we have for ADHD. So I'm very fortunate to be on the panel today with you, Ann, who've done a number of these studies, and we've done a number of studies, and it's well known that it's hard to beat a stimulant medication. So the non-stimulants work, and they're efficacious and useful in certain circumstances, but in terms of just anti-ADHD efficacy, stimulants still have the biggest effect size. They have the most effect on treatment. A lot of people like stimulants because once you get to the correct dose, you know you're at the correct dose. Once you titrate up and it works, it works. How long does it take to get to the effect? Well, If you titrate the medicine up slowly, it may take a little bit of time, but once you get to the correct dose, that's the dose. It doesn't have to accumulate. The other nice part about stimulants are that you don't have to take them every day. So for some people who don't want to be taking stimulants every day, you have the option of taking them or not taking them. Whereas with non-stimulants, you typically have to take them all the time. Other advantages, stimulants have very few drug-drug interactions, essentially no pharmacokinetic. That means, drug reacting with the stimulants in the blood. And there's very little metabolic effect on stimulants. That is that other drugs don't, block the metabolism, and stimulants don't block the metabolism of other drugs. So they're very easy. And finally, safety. These medicines have been around since 1930s, 1937, and they really have a tremendous safety profile. And it's not like we're going to learn a whole lot from a safety perspective that we didn't know previously about stimulants. There are no surprises on the horizon. Some of the disadvantages are the side effect issues that you deal with. And that can include everything that we'll talk about from, the issues with the tolerability of the medications, as well as for people who may have, certain types of use disorders. They can divert the medication to other people. This is an issue on college campuses in particular, or misuse the medications themselves.
Tim, thanks so much. We've talked about many, many different stimulant formulations, and it can be confusing. I have to get out my tables and look things up, especially with dosing, right? Sometimes, especially with the newer dosing now that the FDA has used the base equivalents, and we have all these decimal points. You talked about titrating to maximum symptom control without eliciting adverse events. And I think there is some meta-analysis data with that too, isn't there?
Well, there is, and you really nail it when you say that, which is, the idea that you're just going to say, I'm going to go to 20 milligram equivalents or 30 milligram or 40 milligram equivalents of methylphenidate or 20 or 30 of amphetamine. And that's kind of what I'm just going to aim for, because that's what most people train. It's a strategy, and they do that in some clinical trials. But when you really look in clinical practice, what works better, and even in research studies, what works better, they call it flexible dosing. That is that you're going to work on trying to get the best dose optimized for that individual. You're going to go up on the dose until you get a good outcome, but you're also balancing it against side effects. And there are meta-analysis that have looked at that and have made it really clear. If you look at efficacy, you see that flexible dosing, going up to the right dose, kind of going up, checking your side effects, going up, really gives you a very positive impact on efficacy versus just going to the lowest effective dose. There's also for tolerability, and tolerability is really looked at two different ways. For example, in clinical trials, dropping because of side effects, you don't get that really when you're titrating up slowly and monitoring and comparing it to side effects, and keep going up slowly and check back to see if there are side effects. Another one is acceptability, which is people just drop, maybe not for side effects, but they just don't like the medication feeling. They're just not doing well with it. And again, the data shows that if you kind of walk up on the dose, carefully monitoring, having instructions for parents who are at home, if they're monitoring kids, or if it's an adult, telling them what you're looking for, you're going to get a much, much better outcome than just saying, I'm going to go to 20 milligrams. Just titrate it right up to, Oros 36, or go up to lisdexamfetamine 50 or whatever. You're going to have a much better outcome if you say, let's walk it up. Let me know if you're running into problems, etc. But I also want to balance that with the well-known findings historically that there is a dose-response relationship to medications, which means as you go up on medication dosing, you're tending to get better efficacy. So, for example, in this illustration, using what's called the CANTAB, Spatial Working Memory Task, you can look at these dots, these squares that come and go, and you have to remember which one. It's like the old game of concentration. And if you have individuals with ADHD do that, and you dose them with methylphenidate, no methylphenidate, low, medium, and high, what you see is a dose-dependent really linear reduction in the number of errors, and you want fewer errors on that test. And that's been repeated for a number of different outcomes. So yes, you need to be mindful of side effects, but you also want to be mindful of other things, such as the improvements over time and how they're doing, and have you really optimized the best dose to give them the best effect, not just an effect, but the best effect.
Great. I know in the clinical trials that you and I've done together, we move pretty quickly with medication dosing. We'll start and we may change dosing weekly because you can see a difference that quickly. In clinical practice, I don't move as quickly as that often. And I'll tell patients that we're going to sneak up on your ADHD, right? We're going to start low and we're going to move up. We're going to get there. A lot of my parents are concerned about zombies, right? They don't want their kid to turn into a zombie. I always say we have a no zombie zone here
Yes.
at Center for Psychiatry. No zombies are allowed. And we talked about those side effects, but there's some other adverse events too that people have. And what do you consider most commonly when you're treatment planning?
Yeah, and I think you have to talk to people about the side effects and be sure they know. For example, kids are going to not want to eat lunch, adults either. And in some ways, when they're eating lunch and eating dinner fine on the stimulant, it's probably not doing its job. It's, you're looking for that. So we talk about that. And then what do you do to supplement that if necessary? Be sure kids are drinking water, that they get snacks, that they bring snacks with them. Hey, have them go shopping with whomever to pick up what they might eat when they're like that. Other ones that are common, of course, is difficulty falling asleep. And you want to know, is that at baseline? If it was, did it get worse on the medication? And again, you may choose a slightly shorter duration medicine if you're using stimulants that may not cause problems. It can increase heart rate and blood pressure. It may increase that, but we're really looking for, and it's more of a serious issue, do the kids develop shortness of breath, chest pain, really dizziness and syncopal episodes are probably the biggest thing you got to watch for. Cardiovascular, and that's probably signaling that they have something underlying, and that would be more serious. Hey, don't take the next dose, page me. That kid should have an eval, and if you're an adult, you should go see a cardiologist for that. Other things you worry about is sort of a restlessness that kids can have, and adults complain of that a little bit more, grinding their teeth, dry mouth. One that you have to also think about is if there's complaints about moodiness. I'm really interested, is it during the peak effect, in which case you're going to have to change the preparation or change from methylphenidate to amphetamine or vice versa? Or is it during wear off? And one of the clinical pearls I have, if it's during wear off, you can sometimes use shorter acting, change the formulation to an extended release. If you're still having it, give a microdose of a short acting. A clinical pearl I've learned also is sometimes during wear off, if you have a lot of mood symptoms, beware, because sometimes 2 to 3 years later, that kid actually has an emerging mood disorder. And I actually think that it's actually unmasking that tendency. More serious stuff is really what I was talking about with the cardiovascular. If you get kids who are having explosive outbursts on the medicine, hey, time to stop, reevaluate what's going on. Kids who get paranoid, and then there's rare cases in kids, adults who get psychotic on it. In those situations, you have to stop. That's a time to really reconsider what's going on, what else may be happening with those individuals. And clearly, if you're treating people with substance use, and I do, and I'm, that in high risk individuals who may be in, early recovery for their substance use, you've got to keep an eye on that. And if they're misusing their stimulants, then you better have a strategy for what are you going to do for those individuals.
Great advice, Tim. One of the things I say to parents is don't talk politics when your child's medication is wearing off, right? Or with your adult spouse. We also have a number of non-stimulants, though, in our arsenal. What are some of their advantages over stimulants?
Yeah, and I don't want to poo-poo the non-stimulants. They are so important in our armamentarium. It isn't just stimulants. We have lots of non, and we have new ones. First, I was commenting a little bit about, our concerns about stimulant misuse, and there's quite a bit on college campuses. There's really almost an absence of medication misuse or diversion. It just doesn't happen. The other issue is, we've been commenting on the long days that adults have, that adolescents have, days transit. hey, you can have a longer duration of action because it's not going to keep you up. It's not going to, clip your appetite. And it may also help treat co-occurring disorders. So you may have anxiety and ADHD that can be co-managed with one of the medications, atomoxetine, for example. Depression, you can use certain non-stimulants that will help with depression in that. Kids with tics, the alpha agonists can be helpful, tricyclics. Kids who have sleep disturbances, you can use alpha agonists and some of the non-stimulants, and it may help the ADHD as well as that. They're different than stimulants. And so sometimes, we define ADHD symptoms in part linked to stimulants, but there's a lot of other kind of meta ADHD problems that non-stimulants may address a little bit better than stimulants.
What about the efficacy and tolerability?
Yeah, so again, I don't want to disappoint people. The non-stimulants work. Some people I will have this category, they don't work. I don't find them to work. No, they do. They've been shown in controlled trials, but also in clinical practice, they work. The amount they work is different. So if you look at what are the most effective agents, you're going to have the stimulant medications. In general, the stimulant medications have an effect size of 1. What does that mean? They call it a standard mean deviation, and it's the same thing as really the effect size. If you think of behavior, 1.5 standard deviations outside of the mean is when you start to define abnormal behavior. If you push that 1 back, that means you're almost back to, quote, normal range of behavior. So that's really what the effect size. So if you have an effect size of 1, which is what stimulants have, that means you're really pushing behavior almost back to where it would be indistinguishable. Non-stimulants are roughly in the 0.5, 0.6, sometimes 0.7. So they're 30 to 40% less effective, but they're still quite effective. Let me just remind you, when you give Prozac for depression, that effect size is about 0.4. So our non-stimulants work better for ADHD than Prozac does for depression, and the stimulants much better. But there is relative differences. The stimulants have the most effect, followed by the non-stimulants. And the non-stimulants really are somewhat interchangeable, based on what study was done. Some of them show higher effect, some of them slightly lower, but in general, they work. And the other issue we find is that there's some similarities in outcome between the kids and the adults, where again, the stimulants work better than the non-stimulants in both of those age groups. What you then want to link it to is taking a look at how well are they tolerated, the non-stimulants and stimulants. And what you find is that in general, you tend to find dropouts more. I find this fascinating, dropouts in the placebo groups. That's when you look at the studies and you put it into a Cuisinart and you ask, where are most of the dropouts occurring? It's actually with non-treatment. And that really doesn't surprise you, because people who are in these studies who are undertreated or not being treated fall out of treatment. They don't. Why would you continue? So it's also word-wise of adherence. Using homeopathic or not using non-effective agents is one contributor to non-adherence.
You talked a lot about dose optimization with the stimulants, and obviously we need to dose optimize with the non-stimulants too, but the optimization paradigm is a little bit more complicated, I think, with non-stimulants. Can you talk about that?
Yeah, absolutely. And everybody does this a little bit differently. So when you're starting, I think you have to be a little bit mindful when you start these medicines, and I really appreciate what you said, Ann, about in clinical trials, sometimes they start the medicines a little bit faster. And in clinical practice, we do it a little bit slower. So for example, if you're talking about atomoxetine, hey, I start like with a kid, I'll start maybe 25 milligrams. I'll start it at night. I'll go for a couple of weeks. Why? Because there's a soporific effect. And then I'll move it into the morning on when we're starting week 3. And I do the same for adults. I may start at 40 and then increase to 80. With the non-stimulants, one thing that's important is using these medicines as you're increasing the dose, Usually by 2 to 3 weeks, you should see something. Mostly 60 to 70% of those people are going to respond by week 2, you see something. But certainly by 4 weeks, you should have seen an effect with these medicines. If you see an effect by 4 weeks, the data shows that if you just leave them alone, you'll start to see even more effect to week 6, 8. So if you see an effect, you may not have to increase the dose at that point, and you may. A couple other considerations. Usually with the alpha agonists, we like to walk up relatively slowly for new starts. So probably not more than a 0.1 a day if you're using Clonidine per week, 0.1 per week. And if you're using guanfacine, 1 milligram per week. If you're using guanfacine, titrating up to typically 0.1 milligram per kilogram per day, slowly over weeks is great. By the way, if there's sedation on the alpha agonist, give it a little bit of time. The data shows that after the first month or 2, the sedation gets much better. But again, don't over titrate quickly. And the new kid on the block is Fluoxetine XR. And and for that one, they have a relatively aggressive titration schedule in the package insert. And again, I think you can increase it, but there's no real rush to increase that dose too quickly. You had made the comment before about not rushing the titration with stimulants. And I remind people that ADHD is a very important disorder that we need to treat, but it isn't meningitis. We don't need to intravenously infuse and get the dose instantly. We have time. So take your time. And I think with fluoxetine, as people are getting used to it, I probably would slow down the titration just a little bit, maybe 100 milligrams a day, and then bring it up to 200 over time. And even in adolescence, I would start at 100 probably and bring it up to 200. I don't know if I'd start right at 200. And again, there's no real reason to rush the titration. The medicine works pretty quickly once you get the dose.
Great advice, Tim. Talk a little bit about the adverse events with the non-stimulants, since you spent some time on the stimulants.
Yeah, and so this, what's interesting is the non-stimulants have similarity with each other in terms of the side effects. They're not interchangeable, but you'll see it. So, for example, somnolence is a common one. Think insomnia with stimulants. Think somnolence with the non-stimulants. Although the new kid Fluoxetine may have insomnia associated with it, so monitor that. Not uncommon to see headache, sometimes abdominal pain. Sometimes that's just because they haven't eaten, and sometimes it may be a different mechanism. Probably the one that is the most reportable, and it's actually got a warning for one of this, is irritability. Sometimes you see irritability with atomoxetine, and it can be independent, and you probably have to move on to something. With alpha agonists, often the irritability is related to sleep, somnolence. If you can try to tease that out, it helps. And finally, with all of the medicines we have for ADHD, dry mouth is not a trivial side effect. It's one of the biggest risks for dental caries and stuff is dry mouth. Many of these individuals will love carbohydrates, so they'll use sugary candies, etc. So I would advise about that, especially long-term treatment with them, to be sure good dental hygiene, use water, non-sugar drinks and things. The serious side effects are similar to stimulants. You still worry about cardiovascular with some of them, like the alpha agonists. You have to worry about a slow heart rate, and that can lead to sort of bradycardic episodes. And you'd notice that because the kid has sort of passing out or sort of syncopal episodes. With all the medicines we use, you do worry always about, do you elicit something like bizarre thoughts, suicidal thoughts? Not common, but something to monitor. And that can be in children, adolescents, and adults. And in all individuals who have proclivities to manic episodes, bipolar disorder. You worry about agitation, activation. We have seen, and that's been reported, manic activation with non-stimulants in individuals who have this predisposition to bipolar.
We talked about adjunctive therapy just a little bit. You talked about comorbidities. And when do you use adjunctive therapy with stimulants and non-stimulants?
When you have an incomplete response to the treatment. So you've used, let's say, a stimulant, or let's say you've used a non-stimulant, and you find that you're getting most of the way there, but still there's residual symptoms, or you have to accentuate one part of the day and you can't use a stimulant or you can't use a non-stimulant, then you can use 2 classes of medicines together. So this is one where you can use for example, FDA approval now one of the first combinations that has been FDA approved in all of pediatric psychiatry is to be able to use alpha agonists with stimulant medications. And in particular, studies were done with extended release clonidine and extended release guanfacine mixed with extended release stimulant medications. And what's interesting is you saw relatively robust outcomes. Effect size, again, going back to that of about 0.4, a moderate effect additive to a partial response to a stimulant medication in both cases. When you look at tolerability, there's good tolerability, but what you do get is you tend to get additive side effects. They don't cancel each other. That's an interesting one. So you get the side effects of the stimulant and you get the side effects of the non-stimulant. So be mindful of that, but it is a really terrific option. The other, by the way, use of this combination, in particular, alpha agonists and stimulants, are for kids who have tic disorder. Sometimes people use them for kids who are really impulsive. Sometimes kids who have excessive hyperactivity where you can't control with a stimulant. So this is a combination, I think, to think about, as are the other non-stimulant stimulants, although those are not FDA approved.
Tim, I'm thinking about all of the things that we have in our toolkit. We have quite a few, but we had something that we had to deal with starting about 2 years ago that none of us ever dreamed of, right? This COVID-19 pandemic has really impacted every aspect of healthcare. It's even impacted my therapy dog. When things were shut down, we were in clinic and poor Buddy would run to the door when he would hear a car in the parking lot, like, where are all the patients, right? It impacted even the animals. What tools do you recommend for optimizing care now during the pandemic? We thought a lot of things were behind us, but we keep getting new variants and keep having to deal with this.
Well, and I think there were lessons learned about that. And I agree. And I just want to say what a nightmare it was. And, the course, ADHD just got worse. And it was almost antithetical to what you would want to do with kids, adolescents, and adults who had work with ADHD. And this has been extraordinarily stressful to the kids, the adults, and their families. Virtual non-learning, online learning works for certain people, but this is really hard in this group, for example, and isolation, loneliness, the routine loss, which kids and adults really like routine. So it's been a nightmare. The good news from this is, like you said, what tools? Well, first of all, the use of telehealth. I think that this has opened up telehealth. Now, it's really important to know that almost a decade ago, a big NIH study was done looking at the usefulness of telehealth for ADHD in the management of ADHD. And this was really completed with the understanding that rural areas didn't have access to the Ann Childresses of the world. It was hard for them to drive in and get care if they were 200 miles away. So they did this multi-site large NIH trial that showed that telehealth compared to treatment as usual, in person, et cetera, worked just as well. And in some cases, it beat it. And if you looked at the individual preferences, they loved it. So yes, telehealth can work very well in managing and monitoring that. Most clinics like ourselves are showing higher intake rates in terms of lower no-show rates. And we're also showing much better attendance at the various sessions that we have that are telehealth. Other kind of things that we've learned from this is to use online portals to get information. So people use measurement-based care often in their practice. And I'm a big advocate for using measurement-based care. And it's great. You can do it through portals. People have time to do it before your telehealth visit. You send them an email to a link, and they can list their ADHD symptoms. They can do simple PHQ-9s to look at their depression, or PHQ-2s to reflex. They can do, generalized anxiety assessments. They can do substance use. And just in a few minutes, you get a lot of data that then you can take a look at really well. And that works through portals also. Other things that can be very helpful that have occurred during the COVID time is we can do titrations without seeing people. You can have adults doing their own blood pressure management. You can do an awful lot that we thought you could only do in person through sort of telehealth types of technologies. So these kinds of tools, I think, are here to stay. I think the big question is going to be reimbursements. And I think there's going to be more and more pressure that individuals will be reimbursed, and reconciliation of DEA requirements, state licensing requirements, the Center for Medicare and Medicaid Services. What are they going to require? Most of the indicators seem to show that you're probably going to have to do an in-person first visit. But then after that, I think we're going to see a lot more telehealth given the patient preference and also provider preferences for this type of treatment.
Given all of our new tools and all of the treatment options we have for ADHD and risks and benefits, you did a great job discussing these. But to optimize care, we need more than just the physician. We need a whole management team. Can you talk about the importance of that and help our audience understand how to implement that?
Yeah, and I absolutely agree with you. And practitioners who are prescribing for ADHD, nurse practitioners, physicians, and physicians' assistants, and et cetera, can only do so much. And you really need to work. You need to sometimes mobilize a team. Sometimes there's just not a team. You need to work with that team directly or help the parents through education connect with these teams. It's really important that the primary care physician knows what's going on. If you're a specialty physician or specialty practitioner, that specialists, that you coordinate with specialists, learning, let's say it's a neuropsychological testing you need. What specifically do you need to know? If you're working with pediatric or adult neurology, cardiology, if you're working with diabetes expert, what exactly. In terms of ADHD, I think schools, they're open to what's going to be necessary here. So working directly or working through the parents with the schools is critical to ensure that there's some type of an accommodation or implementation of a plan. Taking a look at the implementation. Is it a 504? Is it an IEP? Parents don't know where to start, and sometimes just help directing them where to start is critical. Additionally, I think it's important that you have on your Rolodex a speed dial to what kind of therapy do you think? Is this a family therapy case? Is this going to be a kid who requires behavioral therapy, cognitive behavioral therapy? That becomes really important because it may not be for the core symptoms of ADHD, but as we've talked about, co-occurring problems are so frequent, and you may or may not be able to fully address those with medicines. And some of them are not really amenable to medicines. That's not the treatment recommendation. So I think that's another sort of coordination that's necessary to ensure that these kids, if they're college students or if you're an adult, that they have what I consider not just symptom reduction, but wellness, that you convert somebody to be a well person so that they can really function optimally.
Oh, what great advice. This has been just an amazing discussion. And I'm hoping that our audience will leave with some clinical pearls. You've had a lot of them for personalizing treatment for children and adults with ADHD. Do you have any concluding remarks that you'd like to share?
Well, I think you just tapped into it in terms of when we're thinking about treating, we have such an armamentarium now of psychotherapy, of pharmacotherapy, and focused on the pharmacotherapy. Think about the patient, think about what conditions they have, what are their real needs, what can they tolerate in terms of the medication? Can they take certain types? Is the formulation, what kind of formulation do you want? And really personalize it. I wish, everybody says we're waiting for precision psychiatry. Well, I consider this sort of the first generation of precision psychiatry, given now we know about co-occurring problems. We know about what kinds of targets we have with ADHD. We have now a tremendous amount of portfolio of medicine or formulations available so that you can really personalize it in a sort of precision manner to treat the individual that's sitting across from you. And I think that it's important not to just use a fixed dose to really work on a flexible titration, to do it in a way that's tolerable, to maximize tolerability, but to really, I guess, I keep coming back to it is either as a single therapy or even if you have to combine it, I really think you need to work to really optimize the treatment the same way with the old radio dials, you get the station just perfect. you really want to get the treatment of ADHD as perfect as you can, because they're going to be on this treatment for a long time. And the data over time shows dramatic improvements in many of the functional problems that people have with ADHD as they grow into adulthood, if you treat them properly and if they stay on their treatment.
What great advice. What great advice, Tim. Let's summarize with our SMART goals. SMART stands for specific, measurable, attainable, relevant, and timely. And we hope our audience will take from this presentation a number of clinical pearls. Tim, you talked about considering patient-specific factors such as age and their goals and their comorbidities, their academic and their work demands when you're developing your treatment plans. You talked about managing ADHD as a lifelong disorder that requires treatment reevaluation as individuals age and transition through life phases. You also talked about identifying differences in the safety and efficacy and formulation and duration of action when you're making treatment selections for ADHD, and establishing an office-based team approach to optimize the management of ADHD. This CME Outfitters snack is one of a 4-part series, and we hope that you'll take advantage of all the short and focused activities in the series. Tim, thank you again for joining me today. I learned a lot, and I hope our audience did too. Thank you to our audience for joining us, and be safe and take care of yourself so you can provide the best care for your patients with ADHD.